The first talk of the day is to be given by our guest from Kolkata, Dr. Rajiv Raman sir. Sir, kindly raise the camera and conversation.
Thank you, Chairperson. And Roshan asked me in the last moment to talk on management of sinusitis. This is a sponsored session by Farmed. So, if you see, sinusitis has been an issue for all of the orthopedic surgeons, whether it's acute sinusitis or chronic sinusitis. And if you want to classify it, various classification systems. Normally, we classify all the sinusitis in either acute, chronic, or subacute type of sinusitis. And now, sinusitis is a very common problem in our day-to-day practice. And why it is important? And first, we should understand what is normal synovium. And normal synovium, what it does, it maintains the volume and composition. And you can see it's like a lubricant with hyaluronic acid, which acts as a lubricant inside the joint. Like any mechanical joint, you need a synovial fluid so that you have a smooth movement of that joint. And if you see that synovial fluid is also important for subchondral bone nutrition and chondrocyte nutrition. So once you have synovitis and once you have some pathology in the knee, ultimately the subchondral bone nutrition and the chondrocyte nutrition will be affected, and that will lead to some amount of cartilage degeneration or bone erosion in due course of time. Normally in our clinical practice, we get patients with either a rheumatoid arthritis or osteoarthritis. And the synovial inflammation is a key factor in both. The only difference is that the erosion is more with the rheumatoid component and it's less with the osteoarthritis component. Because of the pannus formation, you have subchondral bone erosion and cartilage erosion, and the capsular erosion is more with the rheumatoid because of the inflammatory, which are aggressive inflammatory mediators which are there inside the joint in rheumatoid patients. So normally you have a very good articular cartilage. You see it's 2 to 4 millimeter of articular cartilage is there in the knee, and when the synovitis starts, what happens because of the inflammatory mediators, you have some amount of synovial cartilage erosion there. Initial stage, if you see the MRI, you put your scope inside, you will see some amount of linear cartilage dissociation is there, and gradually it increases. And once you have multiple synovial erosion there, you will have symptoms of, in due course of time, osteoarthritis, and this patient will come to you with pain, swelling, and limitation of the knee movement. And finally, sometimes what happens in due course of time, after 4 or 6 months, the thickening of the synovium, and patient usually present with thick synovial tissue, a globular swelling around the. Sometimes in case of synovitis, you will see that the whole of the knee is looking rounded up like that. And in those cases, either you have to go for synovectomy because these are the terminal stage where you can't manage them with the normal medical therapy. So, what are the problems with the synovitis, the acute, subacute, and chronic synovitis? Most of these patients initially come to our clinic with the pain. And gradually, if you don't treat them in proper stage, these patients will have some amount of synovial inflammation, the synechia formation, the pannus formation, and that will lead to poor function of the joint. Whatever joint it has involved, either the knee joint, ankle joint, hip joint, or elbow joint. And when you have a patient with a synovitis, I think its therapeutic challenge is there and how to approach this patient. The most common thing what we start is to put them on analgesia and try to reduce the pain first, so that patient will have then once the patient is having symptomatic improvement, you can start structure modification. And if you see, the sustained synovitis is caused by the immune action, because these inflammatory mediators are sometimes immunodepressants. So some of the autoimmune disease also increases the production of the inflammatory mediators. And if the DEGF mediated inflammatory process, which generally causes the destruction of the synovial tissue and the destruction of the articular cartilage. And finally, what happens in subacute and chronic synovitis, there is release of adhesion molecules, and that causes synechia of the synovium, and ultimately those patients in later stage of the clinical stage came in our usually they came in our clinic with some amount of limitation of the movement also. So this is very important. So when you will address this patient, the best part is when the immune action has started and mediated inflammatory process started, try to stop the process of synovitis in those parts, because once the synovial synechias has occurred, they have gross destruction of the synovial capsular tissue, the inflammatory cells has causes destruction of the cartilage tissue. It's almost the late stage where you can't come back. Then you have to think for some definitive treatment in due course of time. Current treatment modalities, yes, normally we start this patient on NSAID, but be cautious. Sometimes what happens, these patients, you can't put them on chronic NSAID for more than 10 or 14 days because of the cardiac and renal side effects. In some of the chronic synovitis, yes, steroid has a role because to decrease the inflammatory process, and that it acts like a barrier to decrease the inflammatory process, and usually decreases the inflammatory secretion of the inflammatory mediators inside the joint also. And disease modifying drug, yes, definitely. Rheumatoid arthritis or sometimes in the immune modulated diseases, you have to use a DMRD drugs also, and methotrexate also normally we are using. Yes, as I told you, NSAIDs, they have the so normally it's a non-steroidal anti-inflammatory drug, but it has its own side effect, glucocorticoids, disease modified with an methotrexate, all of have some complications. So normally what happens in synovitis is, I will just conclude this session by this final slide, is initiating and direct event in arthropathies. A common finding in arthropathies and has been associated with clinical symptoms, and synovial inflammation is associated with progressive joint failure. So you should treat them early so that these patients can come to you and they don't have any destructive process inside the joint. And arthropathy prevention and management may heavily depend on synovitis management. Thank you.
Thank you, Dr. Rajiv, for a very simple way of talking about a very simple topic, and at the same time it's a very common topic.
Yes.
Common problem. Thank you very much. Now may I invite Dr. Neeraj Kumar.
Can I call Dr. Rakesh? I need to take a chair, please. Someone should be there. Next, sir, you have talk on the parallel plating and its results. Brief.
So good morning everyone. This was a paper published in 2014 JCBR, and this is actually my thesis topic. So as we know, the fracture of distal humerus accounts for approximately 2 to 6% of all the fractures and about 30% of all the elbow fractures. Even with development of knee fixation techniques, the treatment of distal humerus fracture remains a challenge to every orthopedic surgeon. And this is because of the complex distal humerus anatomy, metaphyseal and articular combination, and it's difficult to achieve good results due to the characteristic intra-articular involvement and poor control of the fracture fragments with a close treatment. These fractures treated operatively to achieve anatomical reduction and stable fixation of the fracture fragments. Double plate fixation is standard, and we did a prospective study to evaluate the functional outcome of parallel plating in distal humerus fractures. All the cases were fresh from 2013 January to May 2014. We included all the cases in the study. Informed written consent were taken. Prospective study included 23 patients, and we included both closed and open fracture. Only gustula aneurysm type 1 was included in the study. The patient were excluded if the patient had pre-existing deformity, disability, infection, previous surgical intervention in the involved elbow, and patients who were unfit for surgery or who failed to give consent for the surgery. The patient were taken for surgery after preoperative investigation, fitness, anesthesia, pneumatic tourniquet was used, IV antibiotics for 2 days, IV antibiotics, and post-operatively 5 days of oral antibiotics were given. Grade 1 compound fracture were debrided and closed primarily, and incision 5 centimeters distal and 8 centimeters proximal to the olecranon. ulna was exposed and secured. V-shaped osteotomy about 19 mm distal to the attachment of the triceps was done. A V-shaped Chapman's osteotomy was done, and fracture was fixed and provisionally with favors, and definitive fixation was done with intercondylar screws and 3.5 mm reconstruction or anatomical plates in parallel fashion on medial and lateral columns. The stability of internal fixation was tested by moving the elbow through the range of motion. Olecranon osteotomy was reduced and fixed in with tension band wiring in figure of 8 fashion, and again stability was checked after fixation of the olecranon osteotomy. Tunica was released, hemostasis achieved, and wood closed in layer with a drain in situ. Post-operative period, we kept the limb in elevation, and active movement was the fingers and elbow was encouraged from the second post-operative day. Suction drain was moved after 24 hours, and wound was inspected about 3 to 4 days post-operatively. Antibiotic analysis were given as protocol, and patient was kept in hospital for 14 days post-operatively. Elbow was mobilized through range of motion of, for at least twice daily, and was discharged on the 14th post-operative day. And the flexion, extension, and pronation were advised without loading. Patient was assessed at 3, 6, 12, 24, and 1 year at follow-up. Functional assessment was done on Mayo's elbow performance index and quick dash score. The results, of all these patients range from 18 to 60. Majority of the patients were aged above 30 years, and there were 16 male and 7 female patients. All patients reported within 1 week of injury. 5 patients had open fracture, and there was no case with neurovascular injury or involvement. No patient had one patient had associated pelvic fracture and a femoral shaft fracture. 2 patients were unfit for anesthesia due to medical reasons and had been, hence the operative procedure was done only in 21 patients. Fracture was metaphyseal in 9 cases, V type in 6 patients, T type in 5, Y type in 1 patient, and the duration of surgery, average duration of surgery was 157 minutes, and all the patients followed up till 1 year. 2 cases were lost to follow-up after 6 months. At first follow-up, after 3 weeks, 4 patients showed up with some amount of induration, and it was diagnosed to have a subclinical infection and was treated with antibiotics. These infections subsided with 10 days of antibiotic treatment and did not occur late in the follow-up. So, as we see in the chart, that there is gradual improvement from the first post-operative day to third to 3 months, 6 months, and 1 year follow-up. The change in Mayo's performance index. So we can see the range of motion improved from the first post-operative day to up to 3 months, but gradually there was no change in range of motion after 3 months. Mayo's elbow performance index improved from 5 to 90 by 3 months, and same for DASH score, which improved from 150 to 32 by 3 months. The first week after procedure, the Mayo score was 5, and which gradually increased to 96 by year end. DASH score was 150, and in post-operative week, it decreased down to 31 by the year end follow-up. Similarly, the range of motion in the first week was 21, which improved to 116 by the end of by the year end follow-up. The improvement in range of motion, Mayo score, DASH score, and their statistical signification is shown in the next figure. And you can see the statistical significance is seen up to 3 months in range of motion and in terms of Mayo score and DASH score. The final assessment showed attainment of full range of motion with united fractures and no angular or rotational deformity in patients. 7 patients had 5 degrees short of full extension with fracture union and no angular rotational deformity. 2 patients had 50 degrees short of full extension with united fractures and no angular deformity. These are the post-operative cases of patients having undergone parallel plating with fair amount of function and good union at the time of follow-up. These are the 2 cases. This is another case of follow-up with with 15 degrees short of full extension and a fair amount of about 110-12 degrees of flexion. Both parallel and perpendicular plating advocated in the treatment of intercondylar fractures, and especially the outcome of this study was that especially those fractures which have capitular involvement should undergo parallel plating. Parallel plating construct is more important if you have that is one absolute indication of parallel plating, lateral capitular fractures. Thank you.
We answer the questions simultaneously.
So, Doctor,
Since no questions, thanks Dr. Neeraj for nice presentation of a difficult common injury in a case. Next, Dr. Muhammad Azfar Nawaz. Since he is not here, next Dr. Nishant Kashyap, IGIMS Patna.
Good morning to all of you. Day by day, due to the increased incidence of the musculoskeletal tumor, limb salvage surgery is one of the best options for the preserving the limb after resection of the bone tumor. So, I am going to present limb salvage surgery in primary bone tumor cases in IGMS Patna, functional outcome and its challenges. Now, first of all, you have to know what is limb salvage surgery. Limb salvage surgery helps to preserve the limb by removing the part of the bone involved with the tumor and some of the tissue that surrounds it, and the gap is created, reconstructed with the either bone graft or either by the metal prosthesis or in combination of both. This is a picture showing the proximal femoral graft for reconstruction of the wrist, and another picture showing the reconstruction of the knee by the metal prosthesis, mega prosthesis. Before 1980s, most of the tumor managed with the amputation and disarticulation. But nowadays, due to advancement in orthopedic, bioengineering, radiographic imaging, radiotherapy and the chemotherapy, about 90 to 95% of the cases managed with the limb salvage surgery. Rate of amputation reduced to 5% from 40%. So, our protocol for the limb salvage surgery is, first of all, you have diagnosed the case by clinically and radiologically. After confirmation by the radiology and clinically, you have to confirm the diagnosis by the biopsy, or either by needle biopsy or either by the open biopsy, and confirm the report with the histopathological report. Then finally, staging of the disease should be done. Followed by neoadjuvant chemotherapy, plus minus depends upon the cases and the stages of the disease. And followed by definitive surgery, you have to plan, and followed by chemotherapy and rehabilitation depends upon the stages of the disease. Now coming to independent staging system, in stage 1 and 2A, reconstruction limited to the skeletal stability. No role of chemotherapy in these stages. But in stage 2B and stage 3, limb salvage surgery should be done after neoadjuvant chemotherapy. So finally, the surgical decision should be made following completion of the neoadjuvant chemotherapy. So what is Malawar 3-strike rules? In Malawar it says that if among 4, only 3 are if 3 are involved, the limb reconstruction should be worth considering. But it is not absolute term. So what is the stages? How the limb salvage surgery progresses? First step is tumor resection, followed by skeletal reconstruction, followed by soft tissue coverage and muscle transfer to restore the functions. So currently we have 3 most popular options for the limb salvage surgery. First one is the endoprosthesis, second one is the composite biological reconstruction, and the allograft endoprosthesis combinations. So each of those methods has its short-term and long-term advantages and disadvantages, and the surgeon should consider each patient individually. So our musculoskeletal tumors operated in orthopedic department IGMS last 7 years. Among them, 80 cases from giant cell tumor, about 33.75% among 235 patients. So among them, all the cases, 41 cases landed over the limb salvage surgery. Among them, most commonly megaprosthesis distal femur. So this is the case one, a 30 years male, quantum exoid carcinoma, left proximal humerus. We did a reconstructive surgery by megaprosthesis proximal humerus. This is a 5-year follow-up. This is a functional assessment of 5-year follow-up. Another case, wrist reconstruction. This is a 31-year male, female, in stage 2A, operated in 2017 with reconstruction with the ipsilateral fibular graft. But unfortunately, after 2 years, recurrence developed in ungrafted fibula. So we have to plan for the ulnar translocations, and but during the surgery, the radial artery is injured, and the ulnar translocation is postponed, and we have planned for the arthrodesis of the wrist by the centralization of the wrist on the ulna and fixation with plates and screws. This is a 1-year follow-up X-ray. This is published in JODT. Another wrist reconstruction, a seropositive hepatitis B positive 31-year-old male, in stage 2A, giant cell tumor distal radius, left distal radius. By occupation, he was tailor. This is the X-ray picture and MRI picture. This is intra-op X-ray picture, and this is 16-month follow-up. This is a 2-year follow-up, performing his day-to-day activity, continuing his tailoring job after left wrist reconstructions. Another case of proximal femur reconstructions, a 35-year-old male, elsewhere treated pathological fracture IT with DHS with implant failure, diagnosed as a GCT left proximal femur, in stage 2B with implant in situ. We had managed these cases, 1-year follow-up, 2-year follow-up, 5-year follow-up. This is another case, proximal femur reconstruction, 32-year male, in stage 2A, operated in 2019. This is 6-month follow-up X-ray and 3-year follow-up. This is a video for after 3-year follow-up, patient continuing assisted mobilization and his previous job. Another case, distal femur reconstruction, 34-year male, GCT right distal femur, in stage 2A, operated in 2015. This is intra-op X-ray. This is 4-month follow-up, 5-month follow-up. This is the largest follow-up in my 5-year follow-up. Patient continuing his own business and routine activity. And this is another case, 16 distal femur reconstruction, 18-year female, GCT left distal femur, in stage 2A, operated in 2020. This is a functional assessment, 3-year follow-up, 2-year follow-up picture, video, patient continuing his study and routine activity. So this is published in PubMed journal. Recently, a retrospective cohort analysis of the limb surgery during megaprosthesis in the bone tumor at the tertiary center of the Eastern India. Our relapse-free survival rate is 83.7%, which is comparable to the other studies. So, outcome depends on the stage of the disease, size of the disease, pulmonary and non-pulmonary metastasis, time of the diagnosis, resectable or non-resectable tumor, and surgeon expertise. So, our challenge is a late presentation by the patient due to lack of awareness, cost of implant, expertise, and multidisciplinary approach. So, our future plan is reconstruction of the limb with the allograft pelvic bone reconstruction of the limb with pediatric age group with expandable prosthesis. So our take-home message, limb salvage will become accepted standard method for treatment for resectable bone tumor. A variety of techniques available, megaprosthesis becomes a reliable choice of the surgery for management of bone tumor. Despite complication occurred, the outcome of megaprosthesis is improving by the time. Thank you.
Thank you, Dr. Nishan. Any questions from the house? Now call upon Dr. Vidyasagar, gap balancing checking primary technique.
Good morning, all of you. It was a nice presentation by Dr. Nishan sir. Nowadays, TTR is increasing day by day. Earlier, 2 decades back, it was not so much common. But due to implant designs and patient satisfaction, the TTR is increasing. So still controversy occurs whether to use PS knee or CR knee, like prostate knee or posterior stabilized knee, or so many controversies occur. There is interoperative if we use to how to balance the knee, like measured dissection or gap balancing. So my topic is related to how to soft tissue balancing, how to do soft tissue balancing. So every surgeon wants a soft tissue balance knee with anatomical joint lining. So in which the rectangular gap occurs, the flexion gap and the extension gap both are rectangular without changing the anatomical joint line. The flexion gap should be rectangular, extension gap should be rectangular. So coming to after the radial parapetalar approach, removal of osteophytes, the major concern is how to balance the soft tissue. How to balance the soft tissue? There are basically two techniques. One is the measured dissection technique, and another one is gap balancing technique. The measured dissection technique, the principle lies behind this. The principle lies behind this. We have to dissect the femur first, and we measure the distal femoral cut, and according to that, the implant design we use. So after the exposure, we have to measure the three anatomical landmarks. One of the landmark is transepicondylar axis, but during the operation, sometimes it's find difficult to assess the transepicondylar axis. Another one is right side line, which is 90 degree perpendicular to the transepicondylar axis. Third one is posterior condylar axis. The posterior condylar axis sometimes when 3 degree external rotation is made, it goes perpendicular to the transepicondylar axis. Now, when the distal femoral cut is taken, it can be measured like 9 mm or something that. Now, coming to gap balancing technique, I used to prefer the gap balancing technique. It was derived by Insal and Freeman in 1984, and earlier at that time there was not much anatomical, there were not much implant designs. So basically, this technique relies upon the ligament release before completing the bony resections. So after balancing can be done first in the flexion or in the extension, or sometimes first in the extension then in the flexion. I used to prefer first in extension gap and then the flexion gap. The first step for the gap balancing to check the extension gap and balance it accordingly to get a symmetrical space. The sequence can be removal of osteophyte, then the proximal tibial cut and the distal femoral cut. According to that distal femoral cut, achieving the femoral rotation, and then the posterior condylar resection, and then the triangle. I used to prefer for the patella denervation. I used to prefer denervation to the patella. Now coming to the gap balancing, additional maneuver can be used for the contracted MCL. 16 gauge needle can be taken to pie casting the deep MCL, pie casting the MCL. Coming to extension gap, the tibial cut is typically I used to take 8 mm below the least compromised compartment, or 2 mm from the most decompromised compartment. Coming to distal femoral cut, the distal femoral cut alignment I used to prefer taking intramedullary alignment from the right side line. Now coming to the extension gap, we used to perform, there is no flexion deformity, and before taking the posterior femoral cut, I used to prefer the special block, so there is a posterior condylar cut comes to in the line. There are few cases. First one is a 53-year-old male having severe osteoarthritis and the TKR is done. Another case, 65-year-old male having severe osteoarthritis. Here is a 5-month follow-up. Patient is doing fine. Thank you.
Any questions from the house?
How many patients do get the arthritis
So petrofemoral arthritis is common. Actually, I have done the cases in which not the tri-compartmental arthritis. It was simple bi-compartmental arthritis. So I have not found any case of
The nerve patella, how much does it have the problem with this?
Sir, I have learned denervation of patella. I do not know the
How many
research.
patients do you have?
Yeah, it's fine. Sir,
I have 1 year follow-up, last 1 year follow-up. So I am doing fine. Yes.
Thank you. Presentation.
Good morning everyone. Today I am talking about role and limitations of fluoroscopy in orthopedic surgery. So the objective of this talk is to know about the fluoroscopy limitations in articular fracture and its advantages, the ill effect of radiation, the awareness and of safety guideline education about it, and how we can use it judiciously. The principle of reduction in the radiation doses. So, it actually after the invention of fluoroscopy, the intraoperative decision making and changes in the preoperative plan may be because of fluoroscopy, and it gets better over time because the better protective equipments and the reduction in radiation doses of the C-arm. But it also has one disadvantage, that we are getting more dependent on it because of increased images during the surgery. So this talk is based on the literature search, and if we can talk about the articular mal reduction, how much we can see with the fluoroscopy. Actually, digital X-ray is better than this, as the literature says, and the biological thinking also, even CT is better for fluoroscopy. And the direct visualization, if we can see the joint by our own eye, that is best, which supported by the literature. The one thing which we can stress upon is when you take a fluoroscopy image in the AP view, it actually detects up to 2 millimeter of the malunion, and in the lateral view it's about 5 mm of the malunion, but below this step off and displacement, it's difficult to see by images. Over the fluoroscopy, digital X-ray is better, so sometimes it is advisable to take a X-ray machine in your operating room. If you are suspecting some malunion, then you can take, like in some surgeries like in kyphoplasty, where leakage of cement, minimal cement is not detected by fluoroscopy, it's advisable to take a X-ray then and there. So there are few limitations, like we have to see that 3D anatomy we can imagine by seeing that 2D image when we are taking an image in our operative theatre. There are other limitations, like it also decreases the telomere length of which is responsible for early aging. So which is the Nobel Prize was given in 2009 for that detection. And other like somatic side effects like skin burn, and because we are taking the X-ray images maximum in our right hand, so we should take care of that, although it needs a lot of radiation for this thing. There are other inventions like O-arm, which is which is taking 3D image on the basis of two fluoroscopy image on AP and lateral and make a 3D picture based on that. It is a bit expensive, but the radiation dose is just threefold of the fluoroscopy. If we can compare it with the digital X-ray, it is almost 100 times in the digital X-ray the radiation dose, and in CT scan it is 100 times of the X-ray. So this is quite good, and if we can say for patient it may increase the radiation dose, but for the surgeon actually it is quite less, because it is not needed lot of images. With few images you can do. There are other modalities like biomechanical guidance systems, which relies mainly upon preoperative CT, O-arm image, and visual and biomechanical feedback about quality of articular reduction, and it is use a computer which estimate the joint contact stress as shown in this picture. So you can have quite less. Actually, it is little expensive, but in the articular fracture, the reduction you can improve with this. So the important thing is to know how to protect yourself, how to position yourself. Like if you are standing towards the X-ray tube, you are getting more of the reflected radiation to you, because what we are getting more is actually the reflected radiations, not the direct radiation. If you are standing opposite side, in the image intensifier plate side, in that side the radiation dose is quite less, because you are using the patient as a barrier of radiation also. If you keep the X-ray tube on the upper side, you are getting more reflected radiation from the patient and or the bed to your face and upper part of body, which is not good. If you keep it down, the X-ray tube, it actually is quite less and it is towards your leg. But one more thing which we can stress upon, the lateral view gives almost 4 times of radiation if you compare with the AP X-ray. So whenever it is possible to take a lateral view, AP view, then you can prefer over that. The one more important points to know is that if you keep yourself distant from being the reflected radiation is quite less. Even 18 inches from the C-arm, you will get just 0.1% of the radiation, means that is about 10,000 times less of radiation. This is also important to know that if you are doing a X-ray in the larger body parts, like when you are doing a spine surgery, it needs more time so more radiation. So there is no guideline in our country, but what is the US guideline is less than 50 millisievert per year you can stress upon. This is an initial X-ray when you keep the X-ray in your face and head, and it is getting improved by the day. Now we have even the gloves which is decreases the radiation. There are other things like lead gown, lead glasses, thyroid gland shield. These are the things which you can use, and you should also know how to protect yourself. Like sometimes you keep your back towards the C-arm, that is not good because it is not covered by the lead. If you are doing the laser, then it is also decreases the radiation because you are not need so much of the images. So the take home of this talk is working with radiation is safe if you know. Always keep in your mind how to position and protect yourself. So fluoroscopy is a game changer. There is inadequacy in the fluoroscopy while doing the articular surgery, and the radiation when you are doing the pulse mode or when it is experienced C-arm technician, you are getting less radiation. Thank you so much.
Thank you, Dr. Badani. Any question from the house? Orthopedic surgery.
Good morning, everyone. After a very academic session by my previous colleagues, I'm here to talk on a lighter topic, the future of orthopedics. Just as fictional stories such as 1984 by George Orwell's Star Wars and our post-human future of Francis Fukuyama have not accurately portrayed the future of human race. Predictions about the future of orthopedics made during past years have seldom come to a reality. Thinking back for a moment, let's say 40 years ago, children with Perthes disease might have been on weight bearing for 2 years. Children with scoliosis may have been placed in still traction followed by use of a brace into adolescence. Adults with scoliosis are undergoing spinal fusions, and those with spinal fractures were immobilized in a plaster cast extending from neck to pelvis for many months. Charlie in England had moved forward with an interesting hip replacement, but it had not yet been accepted by the orthopedic community. Orthopedic surgery, much like other surgical specialties, was under the control of general surgery, and including the advent of internal fixation, joint replacement, and arthroscopic surgery, all these goals were greatly assisted by advances in anesthesia and pain relief for patients. The 50 years between 1968 and 2018 have seen great advances in many areas of orthopedics, including internal fixation of fractures, intramedullary nailing and plating techniques, and newer devices. Joint replacements, including joints other than hip and knee, and advent of navigation techniques and robotics in orthopedics. Arthroscopic surgery, including the development of therapeutics as well as diagnostic applications. Minimal invasive techniques, cartilage regeneration, biological implants, genetic engineering. So let's address some initial thoughts about prediction of future. Certainly minimal invasive techniques will be developed further, and stays in hospital become smaller and smaller. Long hospital admission times will be rare except for patients with multiple trauma and other extensive procedures. Several global issues will have major influence of future of orthopedics. All over the world, the population is shifting from rural to urban settings. It is estimated that within the next 10 to 15 years, around 60% of the world's population will live in urban environments, placing enormous demand on healthcare facilities in urban areas, exacerbating the current trauma call and emergency care crisis. Even the longer life expectancies mean that people expect a better quality of life, that too for a longer period than ever before. Along with these longer, more active life comes increased bone and joint injuries and chronic musculoskeletal disease. Arthritis is the most common reason for consulting an orthopedist around the world, and is most important medical problem affecting the quality of life in this extended age group. We can look to the day when the average life expectancy will grow from 80s well into the 90s and beyond. Longer expectancies, we are expecting a rise of 673% in total knee replacements by 2030, and a rise of 174% in total hip replacements. There have been changes in trend in orthopedic education also. A survey in 2005 found that 90% of graduating orthopedic residents enrolled in some or the other post-residency fellowship programs. That rate is lower in other countries globally, that is around 54%, but then definitely they have joined one or the other post-residency fellowship. With advances, there comes responsibility to the orthopedic fraternity. Orthopedic surgeons and medical device companies must continue to work together to introduce new technologies aimed at improving functional outcomes. The orthopedic community must proactively evaluate the effectiveness of these innovations and demonstrate their clinical efficacy, safety, and cost effectiveness. Also, there is need for constant upgradation of knowledge. We must keep abreast with the latest things happening around the world. There has been if we give a cursory glance at the table of content of Journal of Bone and Joint Surgery, there have been current emphasis on cellular and genetic influences in musculoskeletal disorders. AAV2 mediated BFGF gene transfer to digital flexor tendons to increase the healing strength. Concepts that might have seemed like science fiction a few years ago are rapidly becoming mainstream. Orthopedics, microsurgery, tissue engineering, genomics, nanotechnology, computer-assisted surgeries, pharmaceutical agents, and more. We are not left behind in digitization. We have come up with 3D computer modeling technology, 3D virtual simulation and visualization technologies, computer-aided design, computer-aided manufacturing of the implants for hip and knee replacements. biomechanics simulation technologies, robot-assisted navigation technology. If we are talking about the future of orthopedics, the need for a bone adhesive is a challenge that has remained unmet. The concept of a bone glue to repair simple and comminuted fractures as well as to glue orthopedic devices in place is considered a holy grail. Traditional bone cement can be either synthetic or biomimetic material, while not a glue. PMMA was known to be relatively stable in wet environment, and its use to bone cement has become commonplace. Other commonly used synthetic material used include cyanoacrylates, glass ionomers, and polyurethanes. Of all these, including the bone cements, cyanoacrylates have been shown to be easy to use, and in particular, and butyl cyanoacrylate was shown to be good microtensile bond strength when compared to resorbable plates and screws in vitro study, but in vivo, in wet conditions, the performance was not as good. So we are still looking for a perfect bone glue. We have come down to robotic surgeries, hip and knee replacement using state-of-art robotic arm. MECO arm is being extensively used nowadays, but definitely it comes with its pros and cons. It allows to create personalized surgical plans, so position of implants with absolute accuracy, but the learning curves are high and the cost is very high. So is it really advisable to go for a robotic surgery? It's a endless and lengthy topic to discuss. Thank you very much.
Good morning to you all. My presentation is treat-centric for supraparietal tibia nailing. Tibia is most common bone to get fractures at present due to high road traffic accidents. 4 to 6%, out of which proximal tibia accounts for the 5%. Most of the cases are managed by either nailing or plating if fracture is not compound. Out of nailing and plating, nailing is a better option if the fracture is not intra-articular, as it requires the minimum surgical intervention and gives the early range of motion and early use. Now, intramedullary nailing, either it may be the infrapatellar or suprapatellar. In conventional infrapatellar nailing, knee is flexed to more than 90 degrees, either flexed on the table or by hanging on the edge of the table. Thus, in these positions, there is a high chance of fracture to get displaced. The conventional infrapatellar nailing contraindicated in proximal third tibia fracture, as there is a high chance of displacement. In conventional nailing, it is difficult to reduce the proximal fragment. Actually, the pronotum deformity due to pull of patellar tendon and nailing in flex position. While in case of suprapatellar nailing, fracture gets aligned and nail gets inserted. The indications are all the indications for the conventional infrapatellar nailing. Proximal and distal shaft fractures, poor skin condition in the infrapatellar region, segmental fractures, all fascial fractures of the tibia, ipsilateral femur fractures and stiff knee. Now comes to the instrumentations are same as the conventional infrapatellar nailing. In addition, it's required the trocar with entry point locator, special jig with multi-locks as it is called tibial. These are the instruments for the suprapatellar nailing. Now comes to the method. Patient is positioned supine with bolster under the knee to flex the knee to 15 to 20 degrees. Knee joint is inflated to 30 ml of normal saline to test the movement of the patella. Incision given 1 cm above the upper pole of the patella, 2 cm vertical incision is given to quadriceps tendon. For optimum entry, finger should be run under surface of patella and into the knee joint. Insertion of sleeve with trocar to make the entry point. While inserting the trocar, knee should be kept extended to create the space between the patellar to the surface for smooth insertion of the trocar. Entry point should be made by the drill bit for the better assessment. The starting point is just as medial to lateral tibial spine in AP and lateral just anterior to the articular margin as in the conventional nailing. If the fracture reduced by inserting the guide bar, sequential reaming is done with a long flexible reamer, or if there is not long flexible reamer is available, then the trocard is removed to reach up to the distal tibia by the conventional reamers. Then proximal ream by the 30 mm reamer. Finally, there is placement of nail, and K-bar is marking used to the accurate placement of the nail to the subarticular area. Distal log by the free hand. Distal log is 3.9 of 2 companies for suprapatellar landing, that should be kept in mind. Proximal log, at least 4 log should be done, 2 anteromedial and 2 oblique. Proximal log done by the mark on zig 1, 2, AP or 2 central. Position changes as per arrow mark. Thus, through the small incision and better alignment, suprapatellar nailing is a good option. Advantage is does not violate the patellar tendon, less chance of malalignment if used accurately, less knee pain. Disadvantage is that it's a steep learning curve, violate the knee joint, range of motion may be more affected. The conclusion is that the correct starting point remains the crucial part of the surgical procedure. Nailing in the semi-extended position of knee offers an alternative to the traditional infrapatellar approach. The special instrumentation allows the minimize the risk of injury damage to the intra-articular structures. Thus, semi-extended position of knee facilitates the fracture reduce, particularly in proximal third tibia fracture and all diaxial fractures. This approach had excellent outcome in ipsilateral femur shaft fracture, stiff knee, and proximal third tibia fractures. These are the few cases. Thank you.
Thank you, Dr. Ashutosh. Any question from the house?
So we take home message for your lecture today is Doctor.
Talking about movement, there is actually no evidence to show that you have less movement after suprapatellar nailing than regular infrapatellar nailing.
So even in shaft fractures and distal fractures, is it not preferred treatment over nasal nailing?
So let's say this way, it has specific advantages in proximal and distal fractures. For shaft fractures, you can use either. But if you're using one system, you can use it for everything. There's no disadvantage in using this. The only area you have to be careful is when you have a very tight patellofemoral space. Okay, if there's no mobility between the patella and the femur, then they don't recommend that you use this. So you can use a median incision for that, a medial parapatellar approach, and do it in those situations. You don't go through the suprapatellar entry.
It was a wonderful talk. Thank you. So one speaker could not turn up. I think he not responded late. I'm just checking if he is there. So we conclude today's session, first session. Now we have the PG quiz. For that the arrangements has to be made. Yeah, this is the way for the chairperson. Thank you. Sir, Rajesh sir.
So we are concluding this first session of
I will ask Rajesh sir to
The PGs are upstairs and presenting their papers here. So most of the PGs are upstairs presenting their free papers, so you need to call them down first.
Yes, chairpersons will invite them and Rajesh sir will give them their mementos. So we call Dr. M.K. Singh sir again for the form. Please sir. Dr. Rakesh, yeah, you are here. I will request Sir, take the privilege to honor Rajesh sir also with the. नहीं तो फोटो भी ले लीजिए एक तो बनता है. Dr. Neeraj, can you be here? कुछ है? It's not here. Dr. Nishan, thank you. Sir is giving the coffee. What did we call you? Have the coffee for this next time. Yeah. Dr. Janki sir. Hi, please. Please. Chairperson, please. Dr. Rajiv Ranjan. Dr. Rajiv Ranjan. Dr. Ashutosh, please. Someone left? Dr. Anand? Yeah. Please, okay. So, we conclude with the first session. It will take 2 minutes for arrangement of the stage for the PG quiz. Yeah. Dr. Praveen Kumar Shahu, Dr. Arnav, Dr. Swapnil Pridashi, Dr. Shravan Prakash. Anyone here? Yeah, you are? Shravan Prakash. You like to carry on the session till the PG arrangements have been made? You can get your talk before the PG session if you are ready. If you want, we have some time. Till the PG session is getting ready. You can carry on with the session. We can have few talks before the PG quiz is taken because that will take 5 minutes. If you are prepared, I will invite you. So, Dr. He is speaking on post-operative collapse after fracture. That's right?
The spine session. The speaker is Dr. Swam Prakash Das from Patna. His topic is fracture treated by index screw with intersegment reduction, a clinical radiological analysis.
So good morning all. So today I will be talking about the collapse that we are getting after treating a thoracolumbar burst fracture. So this is the study which we did at AIMS Patna. Actually, before starting the topic, so starting with thoracolumbar fracture treatment. Initially there was short segment pedicle screw fixation, but that led to loss of reduction and implant failure. So then came the long segment fixation where there was a problem of spinal stiffness. Then we started the index screw in which we put the screw in the fractured vertebra leading to a 6-screw construct, and that also led to reduction of vertebral height and non-union. And then came the transpedicular intracorporeal bone grafting in which we used to put bone graft in the particular gaps that are present in the vertebral body. But that is also associated with disadvantages like it was leading to vertebral collapse due to non-supporting due to axial loading. So because of all these things, what we did, we combined these two things. That means we combined the index screw plus transpedicular intercorporeal bone grafting, and we did the short segment fixation, because of which we can prevent non-union and we can also provide adequate support to prevent the vertebral collapse. So with this particular thought in our mind, we went forward with this particular study, and our primary objective was to compare the radiological outcomes and the clinical outcomes, and secondary objective was to calculate the average amount of bone graft which was used to augment the anterior vertebral void with the thoracic fractures, also used to estimate the surgical time and the average blood loss, and to study the post-operative complications. So material methods include, it was a kind of pre-post interventional study, and the study duration was of 6 months, and sampling population we used all the patients with thoracic or bust fractures who attended our OPD or trauma and emergency. Total sample size was calculated to be 27, and sampling technique was consecutive sampling. Inclusive criteria which we noted were all the patients who had TLIC score of more than or equal to 4, and age group, and all those patients who had skeletal maturity, the fractures which were less than 2 weeks, and the patients who were willing to participate in the study. We excluded the patients with severe multiple organ injury, patients with bilateral pedicle fractures, port spine, evidence of obvious metastasis, or any kind of revision spine surgery, psychiatric disorder, TLICs less than or equal to 3, patients who were not willing for the surgery, and medically unfit patients, polytrauma patients. So what was the pre-operative procedure which we did? I already told our main motto was to evaluate the patient clinically and radiologically. Clinically we took the help of ACR score and the Davis Wall score and the Davis pain score, and for radiological evaluation we used with the X-ray, CT and MRI. Now X-ray parameters which we took into considerations were the vertebral wedge angle, which is as shown in the diagram, the angle between the superior and the inferior end plate, that is angle E, and this is the vertebral angle, and then the sagittal index, which is vertebral wedge angle minus the baseline sagittal curve at the particular fracture site. Then posterior walls angle, which is A, then anterior body compression, and then the other X-ray parameters like the corpse angle and the regional characteristics. Now, you may be surprised why we have taken so many X-ray parameters into consideration. The reason is that here we were calculating the different kinds of kyphosis, like the regional kyphosis and also the kyphosis which was occurring at the vertebral site. So, in the CT parameters were like location of void in the vertebral body, the status of pedicle, and the vertebral union assessment was done after 6 months. MRI parameters were the posterior longitudinal posterior ligamentous complex integrity, and this was taken into consideration in order to for the TLIC scoring which we were doing. Surgical procedure was a standard posterior midline approach, fractured vertebra and one vertebra above and below were exposed, pedicles were inserted into the adjacent vertebra with freehand technique, rods were connected, distraction of the fracture site was done, then rods were removed from one side and that side the pedicle of the fractured vertebra was probed and then tabbed with 6 mm tab. Same procedure was also repeated for the other side. Then bone grafts were obtained from the spinous process, which we took during time of decompression, that was morselized, and that was measured using a 20 mm syringe, and then using a funnel of 6 mm outer diameter, it was introduced into the vertebral body void through the pedicles which we had tabbed. Then the pedicle screw at the fracture site was inserted, rods were reconnected, and after thorough wound wash, closure was done in layers. Now this is the particular funnel through which we were introducing the morselized bone grafts into the vertebral body void, and then post-operatively we did the assessment with the post-op X-ray on day 1. Then all the patients were also clinically evaluated on post-op day 2, and patients were re-evaluated on first month, second month, third month, and 6th month. And in the 6th month we did the CT in order to see the vertebral body union. So what the results we got? In our study, if you look at the male-female ratio, total 9 male were there, female 8, and median operative time was 71.8 minutes. Average amount of bone graft was 8 ml. And post-operative complications, there was in two cases we got surgical site infections, but fortunately both were not successful. Now this is the whole idea, this is the whole thing which we got in our study. The vertebral wedge angle was this much, and post-op day 2 we can see a classical increase in it, while the posterior wall angle was decreasing. And if we see the 6-month follow-up also, it was continuing. So that indicates, and also the neurological assessment also we can see there was improvement in the neurology also in the patients. But and vertebral body even also we could find there was vertebral body in almost all the patients in the 6 month CT scan. So limitations of our study was that the follow-up period was less, and it was only a 6-month study, and there was no age-specific study also, and also it was done in a single center, and all surgeries could not be performed in the same time period since India. So with this, I will conclude my speech. Thank you. So this is the patient. This was the first patient to be operated. Patient was ACR B, and now patient is improved. Thank you.
What is the neurological status improved by the bone graft?
Sir, actually our main motto was to see the vertebral body collapse and the vertebral body union. Neurological assessment, of course we found there was a neurological improvement, but our main motto of study was not for neurological fixation. It was for seeing the collapse that usually occurs with fixation.
It's going to be long, I think. We are very busy, so that will take some time. So we are trying to incorporate some of the speakers from the second session to the first session, so that we don't waste time in the later half. So we have another speaker present here, Dr. Chandan Sekhar. I would request him to kindly come on stage and brief us on lumbar bicortical pedicular screw fixation, merits and risks. Sir.
Good morning, everyone. Myself, I am going to talk about bicortical pedicle screw fixation, its merits and risks. As you know that pedicle screw fixation is the currently first choice of fixation in dorsal, lumbar and sacral spine. It gives 3-column fixation, hence the highest stability among all the spinal instrumentation present till now. In general consensus, 80% of screw insert into the vertebral body mass is practiced generally. So, to enhance the stability of this pedicle screw, various techniques came into consideration. One of them is bone cement and improvement in design of pedicle screw. But with bone cementing, the high temperature by cement setting kills the surrounding bone, resulting in bone absorption, losing of bone cement intersurfaces, cement leakage, pulmonary embolism, infection. And as we know that revision of such surgeries are quite difficult. And the improved design like dual threaded screw and expansive pedicle screw give some mechanical benefits over routine pedicle screw. But study has found that little to no effect of such designs and cementing in osteoporotic bones. So why this bicortical screw fixation came into existence? First of all, it increases the length of the screw. Second, cadaveric study have shown that the pull-out strength of screw is increased from 20 to 50%. It gives deeper screw penetration, larger contact area between screw and bone, stays it dispersed throughout the heart anterior cortex, thus strengthening the screw fixation. It enhances the internal fixation, thus reduce the screw loosening, displacement and pull-out. It improves our success rate of stability. However, the risk of damaging the anterior blood vessel on the right side inferior vena cava, on the left side aorta. There. From this spectral diagram, we can see the relation of inferior vena cava and the aorta to the anterior vertebral body. The dynamic radiological study has confirmed that the distance between inferior vena cava and anterior vertebral body ranges from 3.53 to 5.23 mm, while the distance between aorta to the anterior vertebral body ranges from 2.32 to 3.76 mm. See, from this picture we can see that what are the benefits of bicortical pedicle over the unicortical pedicle. First of all, the length of the screw increases. Second, the bone contact surface between bone and the screw increases. And third, the stability enhances by the anterior hold of the screw of the vertebral body. So in our setup, we did bicortical screw to evaluate the risk and to safely implement bicortical pedicle screw. We use simple imaging technique to examine the anatomical relationship between the blood vessel and the vertebral body, and explore the way to improve the accuracy of bicortical fixation and reduce the risk of vascular injury. When this slide was made, only 14 patients were considered, but till now it has been thrice to this number. Bicortical fixation screws in dorsal, lumbar and sacral spine were considered ranging from D10 to S1 vertebra. Etiologically traumatic vertebral fracture, degenerative disc collapse, spondylolisthesis, osteoporotic vertebral collapse and spot spine were considered. Another similar set of 14 patients retrospectively considered is previously operated for similar reason in our own setup. Data were collected, comparison were made, 4 to 6 months of study has been done. This is a result of bicortical and unicortical pedicle screws. In our bicortical pedicle screw, only pedicle breakers are found. Of 14 cases, 13 were with pedicle breakage. and unicortical pedicle, one with neurological deficit, one with pedicle breakage, and 48 post-op mortality was 1, and pull-out after 6 weeks post-op was 1. This is my failed case of pedicle screw. Might be due to unicortical pedicle and short segment fixation. It failed. And these are our bicortical fixation. First one is the long segment traumatic vertebral fracture. You can see in 2 of the left side of pedicle breakers are found. Another set PIVD L5S1 with posterior fusion and discectomy. This was a traumatic vertebra with bicortical screw in lumbar spine and even the vertebral fracture. Another spondylolisthesis with bicortical sacral screw with intervertebral body fusion and posterior fusion. These are osteoporotic fractures with bicortical screw in all the lumbar vertebra, even in the osteoporotic vertebra also. And another set is the quad spine, long segment fixation, dorsal lumbar quad spine with bicortical screw in the dorsal spine. This is also a quad spine case, lumbar vertebra, bicortical screw. Though my study was of small size, but we had some good results. In bicortical group, no patient developed vascular neurological complication. There was nil screw throughout, but 3 patients developed pedicle breakage in bicortical group over the unicortical group. So, bicortical pedicle screw insertion required no extra time for fixation with more stability and nil screw pull-out. No vascular neurological complication was identified. Thank you, sir.
It's was a great paper. I think there will be many questions from the audience.
Thank you, Chandan. You have lucky to, you have no any complication of vascular injury by fixing the bicortical, but the pedicle screw is sufficient to stabilize the spine. Any literature you have to by the bicortical screw fixation worldwide?
Sir, some recent papers are coming into existence, but no long-term study has been found yet now. So in my experience, I am putting bicortical up to D8 and D7, sir, with no complication. 8 now, till now. D8, D9 and sacral spine, all bicortical screw, even L4, L5, L3, I do bicortical screw right now.
Dr. Chandan, just a question.
Yes, sir.
You started with osteoporotic, in which it's actually, we do tend to put bicortical screws. That's well documented literature. But some of your studies you showed even traumatic and other which didn't look like osteoporotic. So you mean that even in non-osteoporotic you will use or you are using this bicortical?
Yes, yes, I am using all cases. Traumatic, quad spine, osteoporotic, everything bicortical screw right now. Not every screw is going bicortical, but most of them I try to put bicortical screw.
What's the rationale in having that additional bicortical when you know there is a risk, and in a normal non-osteoporotic bone, you are sufficient, the pedicle screws are sufficient. What I found in some of the cases in which you showed that there was screw pull-out or the loss of correction, primarily it didn't look like only because you had a unicortical screw hold. It was because I'm afraid to say, or like there was no sagittal correction which was achieved in that one particular case you showed.
Yes,
and that was the reason that it failed. It didn't fail because the screw were not bicortical.
Yes.
So achieving a normal sagittal alignment is the prerequisite whether we do a traumatic or a osteoporotic spine. And that's a documented method for having a bicortical purchase. But to rationalize for each and every, well, right now I think that will be overkill, because it's more for an osteoporotic and not for a traumatic or a normal 30-year-old or even a 50-year-old.
Right, sir, right, sir. Actually, I'm getting good hold of that anterior cortex. When the screw passes the anterior cortex, it gives some very hard restriction. You feel satisfactory when you put a pedicle screw with good range of strength. So I'm putting bicortical. Nothing like this, sir. No, sir. I put the probe up to this border of the anterior cortex. Sometimes even I perforate it by mistake. I go, sir. But
unless you perforate it, how will the screw go across?
No, it goes, sir. I don't know how it goes.
Must be osteoporotic then. Huh?
So the thing is like when you perforate it intentionally in a normal person's bone, to perforate intentionally is quite risky because it won't get perforated just by your tap.
Right.
You will have to use the awl. Okay.
Yes,
So to perforate a normal person's bone, I think is very risky because you have to have additional power, your upper stress you will have to create. In the osteoporotic, the moment you put in even a probe,
Yes,
it gets perforated. So there I am actually very happy to put in a bicortical screws because once you do the initial tap, so in osteoporotic, I don't even find it necessary to tap the entire length. So with the probe only many times you can actually perforate that anterior wall, the floor basically, the floor. But in a normal person, even if you just do the tapping, and if you didn't tap the entire length, you will have a difficulty in putting the screw. So perforating a normal person's vertebrae is actually challenging. And if you have some tips, please share with us.
Sir, the tip is you have to angulate and the entry point is far lateral. It's lateral to the critical margin.
You get pedicle breakage in 3 cases out of 10 or 11.
Right, sir. Only because of more lateral entry. I try to angulate it so it breaks the lateral wall of pedicle. That was my experience in this case. And sir, that's good, sir. Whatever in osteoporotic, it gets easily perforated. But somehow, one or twice, by mistake only, I pierced the anterior cortex, and I think the probe has gone around 5 mm more, but still no complication by God's sake.
So,
by God's sake.
That's lucky, not, I mean, something that you have to be aware of, because all along, the sacral screw, yes, you perforate the anterior cortex because there's a distance from the vessels. The higher levels, you are very close to the vessels, and there's always a risk of going through the vessels, so you have to be careful about that.
Yes, sir. Thank you.
For the break paper, we have to, all our learners still, orthopedics is the department which you have to keep on learning till the end. So every new assumption can be taken, you have to take a break your own paper and get it published that it is correct. Till then we are learning, but these are also here, so we don't have to take this wrong message. The message has to be clear that screw fixation in strong bones need not be biparticular, but in osteoporotic bone that is the exception. That is the essential. So all the PG students who have made their groups are requested to sit separately in different places so that we can recognize the groups who are in different groups. Group 1, Group 2, Group 3, Group 4. Get in your own group and be seated separately in the entire hall. That will be good. We don't need a cluster in house so that we are confused who is answering and who is not. Everyone in the hall, all the PG students, make their own group and sit separately in your group of 4.
You should get them in the front.
That can be done. You are all ready with the groups, or we can go ahead with one more paper. Kindly organize yourself. Till then, we have Dr. Swapnil Priyadasi with his paper ready. He is here already on stage. That's great. Carry on, sir. Start.
This is the elimination round, sir. It's the elimination round, sir. That's why.
Good morning, sir. My paper is on percutaneous transverticular vertebroplasty using calcium phosphate bone cement, which is a new modality in osteoporotic vertebral wedge compression fractures. Vertebral compression fractures are one of the most common osteoporotic fractures in old age group, causing significant medical comorbidities. And approximately 1/3 of the patients don't respond to traditional conservative treatment. This leads to increased morbidities. And now percutaneous vertebroplasty is a minimally invasive treatment option being increasingly used, but traditionally it has been used with PMMA, the standard augmentation material. In our study, we have used calcium phosphate bone cement, which has several advantages over PMMA, like it is biodegradable. It has osteoconductive properties, limited or no heat generation, and there is no toxic monomer production like with PMMA. So vertebroplasty works on three theories: mechanical theory, thermal theory and decompression theory. The mechanical theory says that it restores the strength and stiffness of diseased vertebra, and decompression theory says that after vertebroplasty the increased pressure is restored, causing the pain relief. So the aims of the study were to study the functional outcome and the duration and efficacy of pain relief and improvement in disability after vertebroplasty. So the inclusion criteria were painful OVCFs more than 4 weeks old, which were refractory to conservative treatment between age 55 to 80, having regional kyphotic cords angle more than 20 degrees and more than 25% collapse. Those having cord compression neurological deficit, any infections, coagulopathy or vertebra plana were excluded from the study. And total of 21 patients were chosen and operated at our institute. So proper patient selection and pre-op assessment is of utmost importance. We did X-rays, CT scan, and in most of the cases MRI was also done. The pre and post-op functional status was assessed clinically and neurologically using Oswestry Disability Index and Visual Analog Score. The materials used, this is ioxol dye, the vertebroplasty needle with trocar and the pusher, and calcium phosphate hydroxide bone cement. The procedure details are as follows. Level marking was done under CRM in AP and lateral view. Small stab incision was given over the desired site, and then the percutaneous needle entry site, it was taken till the periosteum of the pedicle. Then it is important to note that in the collapsed vertebra, the trajectory of the needle will also change. So in entry site in AP view, the needle should be at the upper outer quadrant of the pedicle, and in the lateral view at the intersection of the base of transverse process in the facet. And then we slowly progress the needle through the mid substance of the pedicle and into the cancellous part of the vertebral body. At the mid pelvicular level, in the lateral view, it's been shown, and in AP view, it should not cross the medial wall of the pedicle. At the posterior border of the vertebral body, it's showing the needle position, and AP view not crossing the medial wall of pedicle anyhow. The final needle position should reach ultimately the anterior third of the vertebral body. Intraosseous venography was done using the dye and the repositioning of the needle was done by either advancement, withdrawal or the rotation of the needle. The cement was prepared by mixing the monomer and polymer, and when the ideal rat tailing toothpaste like consistency was obtained, it was filled into the Neurolock syringe and then injected. And the cement filling was checked continuously for any leaks or extravasation by CR in AP and lateral views. After procedure, the patient was maintained recumbent for the next 2 hours to prevent weight bearing and axial loading while the cement hardened, and patient was made ambulatory the next day. In follow-up, patient was discharged after its second post-op day, and regular follow-up was taken after 15 days, 1, 3 and 6 months. The patients were also given calcium, vitamin D and arachidonic acid supplementation and lumbar bracing along with it. So the observation mean age was of 66 years. There was more female preponderance, and majority had insidious sausage, like they didn't know how it happened. There was low trivial trauma in the other causes. The duration of surgery was just small, 30 to 40 minutes in majority of the cases, showing that it is routinely performed as a day care procedure in many centers. The amount of cement used was around 2 to 4 ml and a mean of 3 ml in all the cases. Majority of the fractures were wedge type of compression fractures, and in almost 50% of the cases, the patients presented late by 2 to 4 months after the injury. This might be due to two facts, that vertebral compression fractures after 4 to 6 months, some of them start healing and the pain subsides, patients don't come, or either patients they can come later with worsening of kyphosis or worsening of pain. Majority of the cases it was unipedicular approach which was used, and if the cement filling was found to be inappropriate, then bipedicular approach was used in 5 cases. So this is the graph showing the operated vertebra. Majority were at the dorsolumbar junction, which is a transition zone, and which has most amount of stress between the single level vertebroplasty is performed in 15 patients and 2 level in 6 patients. So majority we can see it's at the thoracolumbar junction. So we can see the functional outcome pre-op and post-op. There was a drastic improvement, and just day 1 post-op, and it continued in the short follow-up we had of 6 months, even by osteoarthritis disability index, we can see the functional outcome. The outcomes were good. But two things we noticed, that the vertebral wedge angle and the vertebral body compression ratio, which correlated with the height augmentation, there was no significant difference. That means vertebroplasty was not increasing the vertebral height. There were minor complications like 3 minor cement leak into soft tissue, but they were asymptomatic. So these are some cases. 2-level vertebroplasty, 5 cases were done. The follow-ups were good. You can see whole cement filling. So in total we can conclude that vertebral augmentation procedure is accepted, cost-effective, minimally invasive treatment option, and calcium phosphate bone cement is proposed to be similar in efficacy to PMMA with less complication. Proper patient selection is of utmost importance, and we have not seen much improvement in vertebral height augmentation. So it is a promising new procedure, and compared to PMMA, calcium phosphate bone cement is proposed to be similar in efficacy. So thank you.
Thank you, Dr. Sapnil. You have used the calcium phosphate and bone cement. Both are mixed with each other and used separately. Calcium phosphate and bone cement.
No, so it comes like that only, sir. The local Indian made the G bone which comes, it's written calcium phosphate hydroxyapatite bone cement. Actually, it should not be called a bone cement, but it is like that. We have not used PMMA, but like it comes in monomer and polymer. One liquid is there and the powder is there, 2 grams packet. We mixed it on the table.
Mix with the bone cement.
No, it comes in powder form, sir. The polymer and monomer are mixed on table and then injected.
Okay.
Dr. Rajiv sir, be on the stage. The process is that there will be initial round. There are many groups here now. So together they will be answering the session, the questions. There will be 10 questions, and whoever will be in the top 4 will get to the stage for the final round. Clear, everyone?
So all teams are here. Can I get the list? So total 10 teams, yes? Dr. Akash and Dr. Jharuja from AIMS Patna, yes. Dr. Mohit, Dr. Surya Prakash, AIMS Patna, yes. Rajesh Kumar Abhishek, Bhagalpur. Vikram Singh and Amarnath, DMC Darbhanga. Dr. Nihal, Dr. Madan Kumar, NMCH, Patna, yes. Sanjeev Kumar, Abhishek Kumar, DMCH. Neeraj and Pushpendra, Paras. Subhas and Sachin, Paras. Shashi Kumar Praveen, which college? DMCH, yeah. Akif and Rohit, Katihar Media College, done. So, Rahul Rajan, Abhimanyu, all right, you will add it. You have the answer sheet. So, the answer sheet is with you. One team will submit one answer sheet, write your name, mobile number, email ID, and take 1 to 10. And write the correct answer. There should be no overwriting, and don't try to correct it or recorrect it. All right, only one answer, that will be valid. And I would like to call Dr. Anup and Dr. Rajiv Anand sir, please. Our quiz master on the stage. Please.
And make sure there is no overwriting or cutting. That will be considered as a wrong answer. Okay? Okay.
All seniors are requested not to prompt the answer.
So please let them answer. Please do not prompt.
And Samanta sir is the observer.
So Nandura is observer there. So whoever is prompt, he is going to give to one of the PGDs.
And that team will be disqualified.
No. I think no one will prompt.
All is ready?
Yeah.
All are ready? Yes, no?
Done. Welcome guys. So let's have some ground rules. First, every question will stay on the screen for minimum 40 seconds. So you have enough time. And discuss with your partner, and I think don't discuss to your close seat partner, with your own partner only, alright? A bar at the bottom of the screen will change color from left to right and indicate passage of time, and that bar is settled down for 40 seconds.
यहाँ पे नीचे में आएगा हर एक slide.
Mark with the pen the best choice single answer by a cross in the box beside the choice of number A. So you should write in front of your answer sheet A, B, C, D, and then you have to mark. So question 1, A, B, C, D. Or second thing, you can write only the correct option.
There are 10 questions, so you can write serial number 1, 2, 3, 4 up to 10.
Answer.
And leave some space between each number and just write the correct answer when the question
In capital.
comes. In capital.
So marking, correct marking 4 points. Got it? So our tabulator, Dr. Vikas is there. Dr. Roshan and Dr. Samsu. Please, our tabulator, you should be away from the participants. So no one can influence you. So correct marking 4 points. Incorrect marking or use of multiple marking -1. Suppose you are at A, also B, also C, or -1. You see this? So enough time for each question. So don't be in a hurry. Write right answer. You have enough time. Read the question, then read the answer options, and then put your right answer on your answer sheet. Ready? All right. As you can see, at 40 seconds, the whole of the bar will become blue. So this was the sample question. Got it? So let us start.
Yes.
So Boacon in knee MRI C mean A. Bucket handle tear of medial meniscus. B. Meniscal root tear. C. PCL injury. D. Discoid meniscus.
No, they have to just write down their answers.
1. If I done, we can put the next question.
So don't discuss with your other team. Here your second question comes.
Father of orthopedic surgery. A. Nicholas Sande, Hugh John Thomas, Austin Moore, Sir John Charlie. A, B, C, D. You have to write answer like that. Done? So I think 30 seconds is good enough. Moore's approach of hip is also known as southern approach of hip, posterior approach, both, none. Done? Mayer's Macknifer classification is related to which among the following reasons? ACL avulsion from tibia, option A, option B, PCL avulsion from tibia, option C, MCL tear, D, medial meniscus extrusion. Done? Which among the following joint is assessed by Gordon's view? Sternoclavicular joint, distal radioulnar joint, subtalar joint, calcaneocuboid joint. Yeah, yes, sir. I got it. There's a typo here in Gordon's view. Question 6. 20-year male history of locking episode of the knee. So, what is the MRI sign? A. Ghost sign. B. Double PCL sign. C. Sigon sign. D. Posterior translation sign. Which among the following indices is not used to assess the stability of the patellofemoral joint? TTTG ratio, Blackburn-Pell ratio, Insol-Salvetti, Burkhardt ratio. Is not. Question 8. Harjov angle is related to which implant? Canine, option A, option B, DCS barrel plate, C, tibial interlocking nail, D, PTC nail. Question 9. Roof arc angle has been described for femoral head fracture, sternal fracture, Perthes disease, D. hip dislocations. Last question, which is not the principle of compound fracture management? Tendon repair, wound debridement, early closure of wound, arterial repair.
Your time is up now. So I'll request the tabulator to please collect all the answer sheets.
Just sit there.
Please submit your answer sheets and we'll meet after 30.
The very important and most sensitive of this conference, that is the oration. Dr. V.N. Sinha oration, I request our past president, immediate past president, Dr. Manoj Chaudhary sir, or chairperson, secretary BOA, Dr. Mahesh sir, Dr. President BOA, Dr. Sarab sir, or Dr. Bharat sir. Bharat is not here. Aye, Sarab sir. Request Dr. Manoj sir, Manoj Chaudhary sir, please.
Dr. B.N. Sinha was a legend of Indian orthopedics. He was a good teacher, excellent orator, and so many things to be added. Dr. Manoj Chaudhary, our ex-president and very good friend of mine, will deliver his oration. I think Manoj Chaudhary is happiest person in our orthopedics community. He is the happiest person. And he will say about how to be happy, a road to happiness. Manoj Chaudhary, please. Dr. Manoj Chaudhary is a senior orthopedic surgeon, associate professor in Bhagalpur Medical College. He is an ex-national executive member, Indian Orthopedics Association, ex-member Rural Orthopedics Committee, and is a member of Executive Council of Indian Orthopedics Association. May I invite Dr. Manoj Chaudhary to come on the dais, please, please. And past presidents, everyone knows about it. And he has taken many awards, like President Award, Health Excellence Award, so many things to be added. Please.
This session is dedicated to late Dr. V.N. Singh. So let me introduce, many of us may not be knowing about this legendary Dr. V.N. Singh. So let us have his life history. Late Dr. V.N. Singh was born in a family of average farmer on 5th of July 1910 in village Sangrampur in Jahanabad district. His father was late Baldev Singh and he was the eldest of 3 brothers and sisters. He received his primary education at his home village, and after finishing his education, he expressed his desire for further study against the wishes of his father. In retaliation, his family support was stopped. At this juncture, his maternal grandfather and his brother came for his rescue. He passed the matriculation examination in 1926 with merit scholarship. He was very brilliant, very brilliant. With his scholarship, he did his ISC from St. Columbus College, Hazaribagh in 1928 and secured first division. He graduated from prestigious Prince of Wales Medical College, Patna, now known as Patna Medical College, in 1934. Mind it, the Patna Medical College, the Prince of Wales Medical College was established in 1925 and he passed out in 1934. He received Sir Ganesh Dutt Singh Scholarship during his tenure. He did his FRCS from England in 1938. And after a brief tenure as civil assistant surgeon in Lohardaga, Gumla and Ranchi, he joined Prince of Wales Medical College in surgery department. He held the post of head of the department of surgery and later became principal of Prince of Wales Medical College. He was very much loved by the students and he loved his students also. There are so many stories about this. He retired in 1968. He established Nalanda Medical College in Patna. We pay respect and homage to this towering personality. Will you please stand up for a moment? Sir, for a moment, please. This is the true homage to this towering personality. Thank you. I welcome you in this oration and thank you for attending in such a large numbers. We are a part of this mega event organized by Vaishali Orthopedic Society, and we are happy, and this happiness is reflected on our face. But this happiness is not long lasting as we go back to our routine schedule. Many of us may not be as happy as we are here. Happiness in life is different than happiness perceived in some mega event. So we must find out a road to happiness. We, the orthopedic surgeons, do surgeries in addition to prescribing medicines. And some of us are physicians in true sense, prescribing medicines only, not doing operations. For example, rheumatologists. But many of us and most of us do surgeries of one kind or other. For example, trauma, spine, arthroplasty, arthroscopy. And this part of our duty, our job is very, very stressful. This is very stressful. So, we must find out what is the road to happiness. This is truly said that surgeons and stress go hand in hand. A survey was conducted and a survey says that this is the fourth most stressful jobs listed by firefighters, big CEOs and taxi drivers. But we will probably place this one on the top. Surgery is really very stressful. A survey conducted on 8,000 doctors, 501 reported thoughts of suicide during the previous year. People working as surgeons have the most stressful job, with 96.8% saying caring for others is rewarding but traumatic on the same hand. Who are the happiest doctors? Doctors who manage to adjust with prevailing environment and defy stressful situations and maintain their cortisol level within limit. It has been seen that about 15 to 20 milligram of cortisol is secreted in a stressful situation in a normal person. 15 to 20 milligram of cortisol is secreted in a normal person under stressful situations. But this exceeds sometimes 150 milligram in a surgeon performing surgery. And mind it, this is many times higher than a colonel fighting in battlefield. So I will say, or we can say, that saving life is more stressful than fighting for life, fighting for losing life. Saving life is far more stressful than losing life in battlefield. 150 milligram. If we prepare a list of happiest doctors and their specialization, there will be family medicine, ENT, dermatology, anesthesiology, ophthalmology, psychiatry, pediatric, clinical immunology, pathology, nephrology, but no orthopedics. You will not find orthopedics in this. So we are stressed. Now defining happiness. Happiness is a psychology, a state of emotional well-being that a person experiences either in a narrow sense. For example, me delivering this oration and hoping to get more invitations for orations. When a good thing happens in a specific moment. So happiness is a state of emotional well-being that a person experiences either in a narrow sense when good things happen in a specific moment, or more broadly as a positive evolution of one's life and accomplishment overall. For example, blessed with son or daughter, and that is the subjective well-being. We cannot buy happiness. Happiness can only be sensed. And do not wait to be happy. Do not wait to be happy. Happiness is free. Free. Only you need to catch them. Who doesn't want to be happy? We orthopedic surgeons also wish to be. But there are factors that steal happiness, and we need to recognize them and eliminate them. Happiness is a reflection of satisfaction, and this is perceived differently by different people. Some love working, some love money, some love recognition, some love fame, and some love peaceful lifestyle. So let me share my experience. When I was, when I was an intern in Patna Medical College, we had two surgeons, top surgeons, and both had different lifestyles. Both were happy, but both had different lifestyles. One was working since 5 a.m. to 11 p.m., operating not less than 20-30 cases per day, and busy all the time. The other one was cool, calm, operating 3-4 cases per day, gossiping with juniors, sipping tea, and attending Baki Book Club daily. So both were enjoying life, but quite differently. And we are free to choose our own lifestyle for happiness. For a happy life, we have to fix the goal first. What exactly we want? Money, power, prestige, peace of mind, or something else than that. There is a sloka in Sanskrit, very good sloka. Adama dhanam icchanti, dhanam manam cha madhyama, uttama manam icchanti, manameva mahata dhanam. That means, अधम धन की इच्छा करते हैं, मध्यम धन और मान चाहते हैं, उत्तम केवल मान चाहते हैं, क्योंकि मान ही सबसे बड़ा धन है. But for us, both मान, सम्मान and money is very important. For a happy life, wealth and its management is very essential. So financial stability is essential for a happy life. And we doctors earn, but we are very poor at wealth management. If you think of wealth management, early investments in early life give best results. But because the wealth generated is quite high. But at the same time, financial burdens are very high at this early age. For example, loan for nursing home, loan for CR, loan for instruments, and it's repayment. And if some untoward happens, this balance is destabilized. This balance is destabilized. And the people are in stress. For this, I had created BOA Benevolent Fund in my tenure as president, only to help them. Now question is, how to keep ourselves happy? First of all, we need to recognize the stressful inputs and plan a remedy for each of them. First of all, there is a pressure of our family. Why pressure of family? Because we give more importance to work and less to our family. And there is this stability. So we need a balance, perfect balance between work and family. Pressure of society is there. Doctors are drilled at society level. You can get a call at midnight by your relatives, your friends, or some officials. There is a data. There is a data that 45% are the doctors, 45% are afraid of possible violence, 24% are afraid of being sued, and 13 the doctors are drilled at social level. They may get calls at midnight from their relatives, their friends, and officials, you see. There is a data that 45% are afraid of possible violence, 24% are afraid of being sued, and 13% are afraid of criminal prosecution. We must be remembering Dr. Archana case, who had committed suicide because of this pressure. Another thing we will have to consider is doctor-patient relationship, and this relationship is now strained. Doctors who were considered as gods are not considered nowadays as gods, and this relationship needs a CPR. So we need to understand our patients, and these patients can be categorized in 3 groups. Number 1, they are very good. They are faithful. They will come to you and will say that I have come to you, please Dr. Saab, save me. The another one is confused one. They have gained some knowledge from someone, relatives, quacks, and will say utter absurd things. Quite absurd. Like, I have pain in my neck, is this sciatica? Because they know the term sciatica. So they will find this is sciatica. And third one is enlightened one. They gain the knowledge from somewhere. They have more knowledge. Rather, they have knowledge more than they are treating physicians, surgeons, and they are bubbling with knowledge. They will say, why not nailing? Why not plating? Why not titanium? Why this steel? And so on. And this is because of our great legal power. Doctors are threatened by COBRA. Medicare is no longer considered as a bias as before, and now the Medicare is considered as commodity we all know. So what is the remedy? Please I would advise to take some professional endowment policies. There are so many endowment policies, professional endowment policies. Please protect yourself by any of them. They give some peace to our mind. झूठा ही सही. And next one is take the help of association. Mind it, take the help of association. And our Bihar Orthopedic Association is famous for this. This association is active and protects its members from being harassed or humiliated, arrested. And I say it because we had protected many of our colleagues in my tenure as president, and I am thankful to my legal team of that time and the senior members who are sitting here, like Bharat ji, Rajiv ji, Amul Singh is not here, and many of them. So I shall request you to please become members of Bihar Orthopedic Association. This understanding of our patient will not end till I alert you. What this alert is? This was coined by late Dr. K.K. Agrawal. He said that we must understand our patient by alert. A means acknowledge them, give them importance, talk to them, and listen to them. Listen them carefully. Explain everything about their treatment, treatment protocol, outcome, everything. Review what you have said and what you are doing. And lastly, not the least, thank them because they have come to you. And once we follow this rate will be lessened. Once we are comfortable at all these fronts, practice, prestige, paisa, then we become more ambitious and want to become millionaire like Adani, Ambani. Many of us may attend this. There are examples. Many of us have attended this, but most of us will not. And this should not be a cause to our unhappiness. This pandemic has shown that health is of utmost importance. Our health. And this health has two parts, internal and external. Internal part is healthy mind and external part is body, healthy body. For body, we should do some exercises, yoga, and for a healthy mind, we must practice pranayama. And if the healthy mind is in healthy body, the life will be happy. Because mind and body are interconnected. You cannot have a healthy body without healthy mind and healthy mind without healthy body. I have made a pyramid. And you are seeing this pyramid here. Life force, it is in the bottom. What is life force? Life force is we, our family, friends, and environment. And the skill. Second one is the skill. The skill is the engine. This will drive. And more powerful is the skill. More we have the skill, more powerful is the engine, and this will drive us onto the top. Direction is important. This is on the third part. Direction is important and we must be very careful in direction. It may lead us on the top or may downwards also. So direction should be on the positive side. Spirituality We forget sometimes, but this is on the top. And this is the acceptance. For a happy life, the secret lies in balance. Work, family, friends, society, entertainment, and wealth management, health in addition. This is the balance. We will have to face challenges in our life. The challenges will be so many, like this. There are so many challenges. And if we think peacefully, solution will come automatically. This is a very good picture by some painter. This person does not have any money, but all of them, including their cat, dog, everybody is happy. Very good presentation. So, what are the secrets of happiness? I will say that there is no formula. No formula at all. And there is no magic potion that you will drink and become happy. Everybody will have his own way of happiness. Lastly, I shall quote Mahatma Buddha, who has said, there is no path to happiness. Mahatma Buddha has said, there is no path to happiness. Happiness is the path. So, this path is happiness path. Thank you for patient listening.
Thank you, sir. And the most prestigious oration nowadays is finished by our eminent past president, Dr. Manoj Chaudhary, sir. And the topic he selected is a very different kind of thing. Happiness. We all think about happiness, but never come it. And so, by this lecture today, we realize that how we achieve this. And there are so many secrets of this topic which delivered by our prestigious oration to him, and I really thanks to our speaker Dr. Manoj Chaudhary sir for delivering such a nice lecture on this issue. And now I request our President Dr. S.N. Saraf sir and Dr. Bharat sir to felicitate our speaker Dr. Manoj Chaudhary sir.
Sir,
please, Thakka sir, come on the stage. Sol given by Dr. S.N. Saraf sir and memento by Dr. Bharat Singh sir. Memento will give to by Dr. Bharat Singh sir. Thank you, sir.
We'll take this opportunity to honor the chairpersons also. Dr. Naveen Thakkar sir, kindly give a moment to the chairperson. Dr. Hari Prasad, Dr. Mahesh Prasad, Dr. Madhusan sir.
Thank you, sir.
Speakers for the session 6, fine. Two sessions are here. So 2 speakers are left for the session. We had 3 speakers who had already spoken before. We tried to manage the time. Dr. Abhishek Shraf, Is he here for moderation? So I will continue with that. I will take the privilege. I will request Dr. Santosh Kumar sir to be on the chair as a chairperson. Dr. Santosh sir. Dr. Subhash Chandra. Dr. Manoj sir. Dr. Manoj Chaudhary sir, will you be kind to chair the session because we need chairpersons to ask the questions to the speaker.
Yeah. In the meantime, I'd like to announce that we have an Assami course in December 17-18 at King's Patna with a live surgery with the very basics of village road. If somebody is interested, the delegate fees is 4,000 and the PG fees is 2,000. They can contact me. Thank you. Thanks a lot. We have eminent faculty from Assami and all over the country. Thank you.
For the very interesting fine session. First of all, I will welcome all our chairperson and I will be moderating Abhishek Saraf. Abhishek Saraf will be moderating the session for the spine. And may I invite Dr. Praveen Kumar Sahu sir, our very dear, for his comparison of influence of time from injury to surgery on neurological improvement in acute traumatic spine. Okay, so right now sir is not here, so next speaker will be my very dear friend Dr. Arnav Sinha, very innovative. He will be talking on pedicle screw insertion versus distal locking of a nail. Same but a different, a retrospective study of a misdirected pedicle screws. Interesting talk, Arnav.
Good morning everybody. With the permission of the chair, if you look at the slide, on your left hand side is an X-ray image of a femoral nail distal locking hole. And on your left hand side you have got a X-ray image of the pedicle. So are they same and the same? You just got a hole in which you need to put in your screw. So they are same. But after the X-ray image, this is the reality. And that is what makes it different. It's different. There is an invisible danger which is not seen on an X-ray image when we are putting in the pedicle screws. Despite improvements in the design of techniques and insertion techniques, cortical perforation of the pedicle does occur. Because many transgressions are asymptomatic, the true incidence is not known. Like in this case, in this X-ray there are 6 screws which have been put in. And this is a post-operative image. How many of us can say which screw is inside and which screw is out? It was found out that screw number 5 was breaching the cortex. So we did a study of 120 pedicular screws in 30 patients of thoracolumbar spine by a conventional open technique, intraoperative fluoroscopy, which everybody is doing, nothing high-fi, simple surgery. We did a post-op CT in all the patients and tried to find out the percentage of the misdirected screws and the complications arising thereof. And a review of the relevant literature was also done. Why was the CT used? What is the use of a CT? Because in this study by Weinstein, a post-operative AP and lateral view was taken. The screws was fixed under fluoroscopic guidance. This study was done with 8 cadavers. It showed that the X-ray only had a sensitivity of 31%. This study was spheric. He used an X-rays in cadavers, and he said that incorrectly labeled, correctly misplaced screws were usually misplaced medially. This study was favored in 74 screws, 16 patients, X-ray versus CT. He came to the conclusion that definite or questionable violations of the pedicle cortex. If you use a CT versus an X-ray, the discrepancy was 10 times. Inclusion criteria for study: all adult patients who underwent posterior spinal fixation at thoracolumbar spine, regardless of the etiology of the surgery. Exclusion criteria is very important. Some patients didn't want to have a post-operative CT, so those are not included. And cases not having a post-operative CT evaluation with a detailed description of the grade of the screw perforation, scoliosis cases were excluded, and cervical spine fixations were excluded. This was a patient factor and this was the radiologist factor. So our experience was that most of the radiologists didn't want to report it in such a way that what is the amount of cortical perforation. The outcome measures that the accuracy of the screw placement was evaluated by post-operative CT and they was classified according to this. Why 4 millimeter? Because it has been shown that the medial pedicle perforation more than 4 millimeter may endanger the neural elements, although there is no strong evidence in literature. Ensuring violation less than 2 millimeter is safe, most surgeons consider a period of 4 millimeter as a safe zone of pedicle perforation. This is an interesting paper which I find out. It said that the accuracy when you are using a titanium screw is greater than an accuracy in a cobalt chromium screw because there is less CT scanning artifacts in the post-operative CT. Interestingly, there was no identifiable correlation found between the years in clinical practice and the accuracy, suggesting that greater experience does not lead to improved accuracy. This was from this paper. Now look at this X-ray. There are so many screws put in. If you look at an X-ray, what all can we see? We can guess that there is one screw which is out of the cortex. And this is the post-operative CT where we can appreciate that all the 4 screws have reached the cortex anteriorly. And this case has been given to me by Dr. Kiran Kumar Mukhopadhyay sir. The results of our study is that the indications of surgery were varied, mostly traumatic. This is the accuracy graph. This is the frank penetration graph. This is the severity of frank penetration and the complication attributable to the misdirected screws. So correct, we had 56 correct screws. Frank penetration was found in 40, mostly medially. The complication attributable to this misdirection, we had 4 medial, 4 lateral, but out of which thankfully completely all of them resolved at subsequent follow-up. One important finding seen in literature was that the screw positioned with a freehand technique tend to perforate the cortex medially, and the CT placed with CT navigation tend to perforate the pedicle laterally. Normally, if the unintended perforations using CT navigation would be a result of the inherent inaccuracy of the navigation system, the perforations should be randomly distributed medially and laterally, but they were more lateral. The explanation could be the difference between the longitudinal midline axis of the pedicle and the anatomical feasible axis. To avoid too close contact to the facet joint, the surgeon accepts in some cases a lateral perforation, which is called an intended perforation. Therefore, the increased neurological safety proven when the navigation techniques are used could be related not only to the more accurate cruise positioning but also to this lateral cortex violation, which is an intended perforation. We had this limitation of the study. It was a heterogeneous in nature, the study population, the indication of surgery, the different spine levels. We faced some problems, that is the radiological factors and the patient factors. In spite of the limitations, we got published. This is a scoring system used for pedicle screw system. It was found in the literature, but we could not use this system. We also had to talk about the bicortical pedicular system. In this study, it has been said that the authors observed the anatomical relationship between the prevertebral great vessels and simulated bicortical pedicle screws at different transverse angles, exploring the insertion methods. But as of now, this is not recommended. Ideally, the pedicle screw should be completely contained within the pedicle. Pedicle screws that violate the pedicle cortex increase the risk of neurological injury. However, minor violations of the cortex are not uncommon and may be asymptomatic. In these cases, the screw positioner may be acceptable. So may I have just one more minute? Thank you. Ultimately, the patient symptomology is probably the most important factor in determining the acceptable positioning of the screw. This pediguard came in to improve the accuracy, but it has not been widely used now. And we have got an O-arm, neuro monitoring, navigation, everything. Like my dear friend Abhishek Sharaf says, it's like playing with a video game. What I'm not saying, I'm not advocating routine post-op CT in all cases. I'm not saying that. Fluoroscopy guided conventional open method is anyway inferior to other methods. That is not what I'm saying, because at the end of the day, these gadgets are going to help you understand where you are putting in the screw, and then we tend to forget that God has given us the greatest instrument, that is our hands. This is an X-ray intraoperative where this screw was breaching the cortex. It was realized by the surgeon took it out and did a fixation at the other level. So we are all surgeons, we have got a probe in our hand, we palpate all the four walls and determine the accuracy. Because all of us are surgeons, we would agree that an instrument becomes an extension of a surgeon's hand. Thank you.
Eye opener to all the spine surgeons. So all spine surgeons beware of these type of complications during the application of a screw. Thank you.
So may I now call upon Dr. Gyan Ranjan from Ranchi. Here it is written, although I know he is from Darbhanga. A very good friend of mine since childhood. He will be talking on non-MRI clinical and radiological assessment of spinal canal stenosis. The topic becomes very interesting because in our rural sector everywhere MRI is not available and we should know the very basics about it.
Thanks, Abhishek. Actually, my presentation couldn't open there, so I'll try to open it in this laptop. Just a second. I'm thankful to Vaishali Orthopedic Club for giving me a chance to speak on my topic. My friend Pankaj, Rosh and Vinny sir. And of course, it's very nice to see Dr. John here, whom we follow for long. Hopefully we can understand this. Thank you. And some young people also do suffer. In our population in Bihar or Orissa, West Bengal, Eastern UP, we see many tuberculosis patients also. These are a few major causes like TB or infection, trauma or the physiological changes which happens in the society. I'm really sorry, actually I don't know why it's not working, but it will. With the advancement of many newer investigations like MRI, CT scan, digital X-ray, various views of digital X-ray, EMG, NCD, we can calculate other than the clinical assessment. So, what I like to speak is MRI clinical and non-MRI clinical and radiological assessment of spinal canal stenosis. Good afternoon, friends. Stenosis of vertebral canal was seen earlier by the Verwees in 1949. Picardie, Wills and co-workers. Incidence rises during the 5th decade. No gender predominance. Stomiosis with degenerative spondylolisthesis coronary in women. Central canal stenosis. Ligamentum flavum stiffening, redundancy, hypertrophy, disc protrusion, spondylolisthesis, facial joint hypertrophy and cyst. Lumbar canal stenosis. Common cause is lumbar radiculopathy. Three distinct regions. Lateral recess or influence zone, the mid zone, intervertebral foramen and the exit zone. Instability can be due to degeneration of the spinal column because of instability. Torsion and angular can result neural compression, degenerative spondylolisthesis common 4th and 5th lumbar vertebra. Neuropathophysiology for the same amount of and level of stenosis, the different amount and type of pain in different individuals is seen. Patient may clinically improve despite of worsening the stenosis. Etiology of low back pain and radiculopathy is multifactorial: compression, chemical insult, muscular and nutritive insufficiency, heredity, and aberrant spinal column structures. Radiculopathy is seen like numbness, hypersensitivity, and pain result from ectopic firing of affected roots. Physical compression of nerve roots may not result in pain. Chemically mediated inflammation causes pain. Vascular insufficiency, intrinsic and extrinsic, do play a role of spinal canal stenosis. Clinical diagnosis is not on all the patients. Many improve over time. Some remain same. A few worsen. Natural history is relatively benign but protracted. Therefore, worth trial of conservative treatment. Very sensitive, symptomatic disease warrants surgery. Lateral recess disease, overall results similar to spinal canal stenosis. History may remain, the patient in history, patient may remain asymptomatic to significant compression. There can be congenital stenosis like in 30s and 40s, degenerative stenosis of 50s and 60s, which we commonly see in old days. Many postmenopausal osteoporosis in women or women with a history of prostatectomy. And female to male ratio is 3.1 to 5.1. There can be hormonal influence. What I said previously, that due to hysterectomy, there is estrogen factor is imbalanced, and that leads to osteoporosis. Associated spondylolisthesis, majority low back pain, that is 65%. New onset of lower extremity discomfort, the worsen of standing and walking, often radiation to buttock and tailbone like occurrent. Extension of the back worsen symptoms, leg pain in about 80%, neurogenic claudication, pathogonopathy of spinal stenosis. Instead, could be radicular pain also. Forward flexion increases canal diameter and the symptom gets relieved. So claudication is actively related, classically radiculopathy, common with the lateral recess stenosis, localized to a specific dermatome. Later on, the motor of reflex changes may occur. L5 root involvement is the commonest. Lateral leg pain, EHL weakness, and tibialis anterior weakness. That is very commonly seen. Claudication and radiculopathy may be present together. These are the few cases we can see in this. The L5S1, this X-ray. The changes in L5S1 you can see here. And this is another case, Savita Das, 56-year-old female. She has compromised in walking a distance and standing erect every time for last 3 years. Some difficulty in squatting and getting up. Knee early osteoarthritis. Clinically, spinal canal stenosis examined on 19th April 2022. And this is Lucky Gora, 60-year-old female, 2013. Scoliosis was diagnosed by orthopedic surgeon. No symptom attributed to spinal canal stenosis. Then recent low back pain. Completely walking distance, standing erect, confirmed, and examination was on 19th April. These are my few cases. As I think I finished with my time. Thank you so much. Thank you.
Chairing the session. So thank you, Gan. It was indeed a good talk. Definitely a dermatologist with claudication pain gives a good idea of us to assess the lumbar canal stenosis. Our next talk is by Dr. Abhishek Kumar Das from Patna. He will be talking on transcutaneous neuromodulation as a treatment modality for painful cutaneous nerves, a prospective study on functional outcome. He will be talking on.
Thank you, Dr. Abhishek, for introducing me and respect talk on this topic, which is a bit of a dry topic. At the fag end of this conference, talking about pain is no fun, but those who are in real pain appreciate this treatment modality, which is very simple and is very effective in a complex scenario. I am Dr. Abhishek Das, working as consultant arthroscopy and joint replacement surgeon at Big Apollo Spectra Hospital, Patna. This work was done at Wrightington Upper Limb Unit in UK, and I acknowledge the guidance of Mr. C.Y. Young, who was the consultant there. This is the whole setup. So what is neuromodulation? Neuromodulation is the affecting a nerve stimulation by giving a guided stimulus. In our case, it is an electrical stimulus which we give through a handheld device, that is a pageant neuromodulation device. It is basically a TPLS device which should not be confused with TENS, because TENS is a high frequency electrical stimulus, whereas in this a very low frequency up to 2 Hz is delivered to a cutaneous nerve. Here you can see the hand of Mr. Ang where he is delivering the stimulus to himself, and the bottom picture you can see there is a scar where a patient had previous surgery and a cutaneous neuroma. So it was delivered as an outpatient setup of 6 weekly sessions delivered by a specialist nurse. Patient comes in, they have this TPLS done for 6 sessions, 10 minutes each, and after the end of each session, we record the pain outcomes for all the patients for our data purposes. Those who do not respond in 6 weeks go to the second arm of the study, which is a neuroma surgery. The importance of all this treatment is because neuroma surgery is quite messy with results which are not predictable. In these complex scenarios, if we can give a treatment which is non-operative, it is very much appreciated by the patient. So what's the aim of this study? It is to report the outcome of neuromodulation as an outpatient non-invasive therapy for painful cutaneous neuromas. How do we diagnose it is a cutaneous neuroma? By clinical examination at the site where there is a previous scar or an injury, and we give xylocaine locally, and if it relieves the pain, then it more or less confirms your diagnosis. The database was managed prospectively, however the study was a retrospective review. It has already been published in International Society of Hand Surgery in Berlin 2 years ago. The data set includes patients from October 2015 to 2018 presented in the Wrightington upper limb unit, 50 patients, 25 males and 25 females. Mean age range 47 years. All patients received optimization of medical therapy, which is various types of capsaicin cream and other things which we are aware of, as well as physiotherapy and desensitization physiotherapy in particular, before proceeding to neuromodulation. What were the causative factors? So most common was surgery. Some simple surgeries like De Quervain's tenosynovectomy release, carpal tunnel release, they in fact caused cutaneous neuroma, out of which superficial radial nerve was very common. Trauma was second most common, laceration injuries, stab injuries, and third most common was dog bite. So something as innocuous as walking a dog can give you a lot of pain in your life. So this is the nerve-wise distribution. The most common involvement was superficial radial nerve, and we feel the reason is the nerve course lies in the course of this nerve lies exactly where your approach to the CMC and the basal joint of the thumb would be. So it is commonly involved in a lot of thumb surgeries. Then digital nerves were also commonly involved, dorsal ulnar cutaneous nerve, and almost all the nerves, you name it, and you can get a neuroma there. Now, this is a very important slide. We had 2 groups, 18 of them were the ones who got treated with neuromodulation and remained in the non-operative group, whereas 32 who did not respond moved over to neuroma surgery group. The mean age, there was no difference. However, if you look at the pre-neuromodulation VAS group, there is a statistically significant difference in pain in both the pre and post neuromodulation group. So why is this important? So if patients start responding, then automatically they don't go towards surgery, and there are lots of complex factors involved in pain. So sometimes at the very outset we can predict that those who will respond will eventually do better. Those who will not respond and move on to neuroma surgery may not actually have very good pain relief even in the long run. So in conclusion, neuromodulation does work. The results may look very grim, that is only 33% got a very good outcome. Remaining 66% actually needed neuroma surgery. But if you look at these patients subset, they are complex patients with chronic pain, and even 1/3 of them can avoid neuroma surgery. It is life-changing for them. So neuromodulation does offer symptom relief and can avoid surgery, messy surgery in these patient subgroup, and we definitely recommend it because it is safe, effective, and a non-invasive therapy. Thank you. And this is C.Y. Young, my guide in Wrightington, and the other one is Puneet Monga, with whom I did lots of shoulder surgeries, and we are getting ready to do a shoulder arthroplasty. Thank you.
Thank you, Dr. Abhishek, for this interesting and new modality of treatment, which we can see. Now, one by one, I will be calling up the speakers for the felicitation. First of Arnav, Dr. Arnav Sinha, can you come on the stage? Okay, for discussion part, anyone wants to ask any question?